Good morning, everyone. Sorry. Yeah. The topic is low cost wide field OCT. I don't have any financial interest in this. OCT has proven to be a very useful tool for screening and diagnosis of various macular and optic disc disorders. We all use OCT routinely in our OPD setups for diagnosing pre-cataract patients, for ARMD, for DME, etc. The most commonly used OCTs in the current clinical practices are spectral domain OCTs, and which are traditionally have a limitation of lesser scan area as compared to the newer generation OCTs of Strepsos or newer generation spectral domain OCTs. The OCTs which I have used previously have a scan area of 6 mm or 9 mm at the most at the macular area, where SS OCTs have 12 mm or even up to 18 mm now OCTs have come. Thus, the lesion extensions of edema, SRFs, CSR, etc., which may be present in the perimacular area, may be missed in a single macular scan. Many times the OCTs are done by our assistants, not by the doctors themselves. So we may have to ask our assistants again and again to do the peripheral scan to show the extent of the CSR, so that we may rule it out that it is not a shallow RD. To overcome this, we propose a low-cost technique to increase the scan length, thus be able to screen most of the area within the vascular arcades in a single scan. Thus, we did a study where 10 patients with various indications for OCT screening, which included diabetic retinopathy, preoperative screening for cataract surgery, ARMD, CME, and CSR were selected. The machine which I used was a Topcon Maestro 1. The default scan length in this OCT is 6 mm in the radial configuration for macular area, and the macular OCT was performed, the image thus obtained was analyzed. Now, another OCT was performed in the same configuration, but with the patient wearing a +20 diopter aspheric glasses. The image thus obtained was analyzed and compared with the images obtained without wearing the spectacles. These are the glasses which we use for the patient, and this is how the patient sits in front of the OCT wearing the glasses. The scan length in the OCTs done with the spectacles was about 1.5 times larger than the scan length without the spectacles. The distance from the optic disc to fovea is about 4 to 4.5 millimeters in normal individuals. Thus, the scan with spectacles covered the entire area between the temporal border of the optic disc and the vascular arcades in a single scan. Now, this is the smaller area is the scan covered without the glasses, and the larger area is the scan covered when the glasses were put. Mind you, this is for a normal individual. In a myopic individual and a highly hypermetropic individual, the area covered will be different because the optics will change. Now, this is how it will look. With +20 diopter spectacles, there is a larger scan area, whereas without the spectacles, only the small box area will be covered, which is showing in the lower screen. In a case of a right eye BRVO, we can see that the extent of the BRVO is till much peripheral area than shown with just the without spectacles. In a case of NPDR, we can see there are some hard exudate lesions present outside the scan area of a without a spectacle scan. Now, this is how the optics work. The right rays from a wider region are converged by +20 diopter lens, thus giving a wide field OCT image. The patients who underwent OCT with +20 diopter spectacles had an increased scan length as compared to those without spectacles. This helps in screening of patients of diabetic retinopathy, BRVO, preoperative immature cataract screening, ARMD, CSI, etc. for extent of edema. The limitations are that the system has only been tested on one OCT. However, basic optics of any OCT machine are same, so it should work with most OCT machines. The parameters like macular thickness, volume, etc., which are assessed by the OCT software, will not be consistent since the software is not configured for using an extra lens. This innovation helps in increasing the field of imaging and thus can capture perimacular areas which might have been missed earlier. The cost of this lens is only 1,000 rupees approximately, so it's a very economical project. Thank you.
Dr. Ankit, it's a nice, innovative way of doing the things. But what is the clinical implication? Because most of the things what we want to see in an OCT is the central macula.
Yes, sir.
So what extra information do you get by having this wide field OCT? Like in a DME, as you mentioned, it's the hard exudate and near the arcade. But how does it help in my treatment?
So it doesn't really help that much in the treatment, but we can actually record it, it's present, and later on, the DME is a progressive disease. The DME is not going to resolve usually. Most of the patients are who are diabetics it keeps progressing. So when we see the patient again at a later stage, we can know that there was some peripheral hydroxyurea were present, which have it has increased and the macular area has now involved again. So secondly, sir, in CSR, the extent of CSR is very important. A lot of times in a single scan, if it's a huge CSR, we might even miss the peripheral extent of the CSR. We might miss some PEDs which are present outside the scan area. So this will show that those PEDs or the extent of the CSR can be shown. If it's a shallow RD, mimicking a CSR, so we might be able to know that it's not a CSR, it's a shallow RD because it's going outside the arcades. Now we have to properly examine using IDO again to see how far it is, if it's in break or there or not.
I think in the peripheral PCV, this can be used. Obviously,
Yes,
the
sir.
field needs to be enlarged more.
Yes.
When you are using the spectacles, does it reduces the signal strength?
Yes, slightly reducing the signal strength, sir. But if the cornea and the lens are relatively clear, then we are getting good images. But yes, if lens is cloudy, then the signal strength is slightly reduced.
Thank you.
No, I want to defend you by telling that it will be very useful in posterior uveitis.
Thank you, sir.
Thank you, Dr. Ankit. You can collect your certificate.